everyone, welcome to TriRide. This is Pack 365. Myself Srija. Today in this session you are going to learn about the continuation of ICD-10-CM coding guidelines for certain infectious and parasitic diseases. So in the earlier session you have learned about sepsis and severe sepsis. So how to code. So what are the coding guidelines for severe sepsis and sepsis without shock or with shock? So here is a guideline for sepsis or severe sepsis with a localized infection. So a localized infection means an infection affecting a specific site such as pneumonia, lungs, cellulitis, skin, UTI, urinary tract and wound infection. So sepsis means the localized infection has entered the bloodstream and caused a systemic reaction. So what is a guideline? If a reason for admission is sepsis or severe sepsis, plus a localized infection. So how do you code? What are the coding guidelines? So you have to code the underlying systemic infection first. So for example, A41.9. So sepsis unspecified organism. So you have to code the underlying systemic infection first. And then you have to code the localized infection next as a secondary diagnosis. For example, J18.9 for pneumonia. If severe sepsis is present, so you have to assign the code R65.2 for severe sepsis as a secondary code. So you have to add specific organ dysfunction codes, for example, like acute kidney failure N17.9. So even though the patient also has a pneumonia or cellulitis, the sepsis is more serious. So it becomes a principal diagnosis. So next rule is if the patient is admitted for a localized infection and sepsis develops after admission. So what is the coding rule? The first is localized infection is coded as first. For example, J18.9 for pneumonia. So you have to then code the appropriate sepsis or severe sepsis codes. For example, A41.9 for sepsis and R65.2 for severe sepsis. So if organ dysfunction is present, why? Because the localized infection was the reason for admission, but not the sepsis. So there is a special note for hemolytic uremic syndrome. So if severe sepsis occurs with HUS, you have to follow the guidelines regarding IC1D9. So this is a special case with unique sequencing rules. This is an exception for the sepsis codes. So next guideline is sepsis due to a post-procedural infection. So this refers to the sepsis caused by a complication of a medical procedure such as surgery, catheter insertion, dialysis, wound closure, device placement, pacemaker, central line, etc. So what is the documentation of a causal relationship? So coding requires clear documentation from the provider. So the procedure caused the infection. That infection led to sepsis. So examples of acceptable provider documentation. Sepsis due to a post-operative wound infection, post-procedural sepsis, sepsis secondary to the central line infection. So you cannot assume the infection is due to a procedure. So it must be clearly stated or implied by the provider. So second case, sepsis due to a post-procedural infection. So when documentation confirms the causation. So post-procedural sepsis means sepsis caused by a complication of a medical or surgical procedure. So coding rules for this situation are very strict and different from regular sepsis coding. So sepsis following a post-procedural wound infection. So this refers to infections in the surgical sites leading to the sepsis. So what is the coding rule? You have to use a code that identifies the type or site of the surgical wound infection first. So you have to assign the code T81.41, that is T81.43. So infection following a procedure, surgical site like various areas. And T81.49, infection following a procedure, other surgical site. And O86.00 to O86.03. So this code category is obstetric surgical wound infection. It refers to. So O86.09, it refers to other obstetric surgical wound infections. So these codes, they must be sequenced first because they identify the cause of the sepsis. So if a patient develops sepsis due to an abdominal surgical wound infection after an appendectomy, so the principal diagnosis is T81.42, which refers to the infection of the abdominal surgical site. So next guideline is sepsis following a procedure. So after sequencing the wound infection code, you have to assign T81.44, that is sepsis following a procedure, and O86.04, sepsis following an obstetrical procedure. So these codes, they show that the complication progressed to sepsis. So you have to add a code for the organism. So for example, like B95.62 for Staphylococcus aureus, B96.20 for E. coli, and B95 to B97 range. So third guideline is if a patient has severe sepsis. Here it is. Yeah. So if a patient has severe sepsis, if he has an organ failure, for example, like acute kidney failure, respiratory failure, or septic shock, so then you have to assign the code R65.2 for severe sepsis. So these are the codes for organ dysfunctions. For example, like N17.9 and J96.00. So severe sepsis codes R65.2. They are never sequenced first. So this is the important point you have to remember. So severe sepsis code R65.2 is never sequenced first. So then next guideline is about infections following infusion, transfusion, injection or immunization. So this covers the infections caused by IV infusion or blood transfusion, therapeutic injection or vaccination. So you have to code first from T80.2, nothing but the infections following infusion, transfusion or injection. T88.0, infection following the immunization. So these codes, they identify the cause, the medical treatment that resulted in the infection. So then you have to code a specific infection. For example, like A41.9, you have to add the organism codes B95 to B97. So then you have to add R65.2 if severe sepsis is present. So then severe sepsis with infections following infusion, injection or immunization. So if severe sepsis occurs, you must assign R65.2 severe sepsis and codes for organ dysfunction. So never use A41.X as a principal diagnosis for post-procedural sepsis. So because the procedure is the cause, so the complication code must come first. So you have to always check the documentation for the causation words like due to, secondary to, caused by the procedure, or post-procedure, or after surgery. So always add the organism codes and organ dysfunction codes whenever it is applicable. So next guideline is about post-procedural infection and post-procedural septic shock. So this explains how to code septic shock caused by the complications of a medical or surgical procedure. So if a post-procedural infection leads to a post-procedural septic shock, so what is the coding sequence? First, you have to assign the complication code for sepsis due to a post-procedural infection. For example, like T81.44, sepsis following a procedure. So then you have to assign T81.12 for post-procedural septic shock. So this shows you the infection occurred due to a procedure and it is advanced into a septic shock. So you should not assign R65.21, severe sepsis with severe septic shock. Why? Because T81.12 already represents the septic shock in a post-procedural context. So you have to use both, would be double coding. So then you have to assign the additional codes for organ dysfunction. So even though you cannot use R65.21, you must still code the patient's organ dysfunctions. So example like acute kidney failure, N17.9, acute respiratory failure, J96.00, and liver failure, K72.00. So septic shock, it always includes the organ dysfunction. So organ failure codes must be added. So the sixth guideline is sepsis and severe sepsis associated with a non-infectious process, nothing but a condition. So sometimes patient has a non-infectious condition that can lead to an infection, which again leads to a sepsis. So examples of these non-infectious conditions are trauma, burns, crush injury, internal injury, chemical irritation, and wounds from the accidents. So non-infectious condition, it gives rise to infection and then sepsis. So what is the coding rule? If a documentation clearly links them, so you have to code the non-infection condition first. For example, like burn, T20 to T25, fracture, S52.X, or trauma, multiple injury codes. So then you have to code the infection. Example like cellulitis L03.X and pneumonia Z18.X. So you have to then code the sepsis or severe sepsis. So example A41.X for sepsis, R65.2 for severe sepsis plus organ dysfunction. So why? Because the non-infectious condition is the underlying cause. So I in a ICD-10-CM underlying cause is sequenced first. So if a severe sepsis is present, so you have to assign R65.2 and organ dysfunction codes. So here is an example. If a patient is diagnosed with third degree burn, he develops a own infection and he progresses to severe sepsis with acute kidney failure. So what is the coding sequence? Burn is the principal diagnosis, infection of burn own, sepsis, and R65.2 for severe sepsis. So N17.9 for acute kidney failure. So septic shock in post-procedural cases uses T81.12 but not R65.21. So always look for the provided documentation that links the conditions due to secondary to caused by and sequence based upon the underlying cause of the sepsis. Non-infectious causes always come before infection and sepsis, and severe sepsis must always include organ dysfunction coding. So it is not necessary to assign a code from R65.1. So what does this mean? R65.1, it is used for systemic inflammatory response syndrome, which is caused by non-infectious condition such as trauma, burns, pancreatitis, major surgery, and crush injuries. But when the non-infectious condition, it leads to infection, then sepsis. So you should not use R65.1. Why you should not use? Because R65.1, it describes non-infectious SIRS. So once infection is present, we use sepsis codes but not SIRS. So never combine. You should not combine R65.1 with R65.2 or sepsis codes. So if the infection meets the definition of principal diagnosis, then the infection should be sequenced first. So however, the guideline also says when both the non-infectious condition and the infection meet criteria for principal diagnosis, either may be sequenced first. Example like a patient is admitted with burn injury, burn own infection and sepsis. So both burn and infection, they may meet with principal diagnosis definition. So coder chooses based upon the circumstances of the admission and or the provider statement. So only one code from R65 category should be assigned. So if you code R65.2 severe sepsis, you must not code R65.1, that is SIRS of non-infectious origin. So one R65 for patient. So the fourth guideline is non-infectious condition, infection or severe sepsis. So what is the coding rule? If a non-infectious condition causes an infection that progresses to severe sepsis, so you have to code a non-infectious condition first. So example like burn, trauma, pancreatitis and injury. So then you have to code the infection. So then code R65.2 for severe sepsis or organ dysfunction codes. So there is an example. There is a crush injury which leads to wound infection and which leads to severe sepsis with acute kidney failure. So what is the coding sequence? First crush injury followed by wound infection followed by sepsis, then severe sepsis, and at last acute kidney failure, that is organ dysfunction. So this is the sequence how you have to code the sepsis related cases. So then you should not assign R65.1 when severe sepsis is present. So R65.1 is for SIRS from non-infectious causes. So R65.2 is for severe sepsis, that is infection plus organ dysfunction. So they are mutually exclusive. So the seventh guideline is sepsis and septic shock, complicating abortion, pregnancy, childbirth and the puerperium. So this introduces a sepsis guideline specific to the obstetric patients. So coding for pregnancy related infections, they follow the special rules in ICD-10-CM Chapter 15. So what are the example codes include? O03.87 for septic abortion, O85 for puerperal sepsis, O86.04 for sepsis following the obstetrical procedure. Then O75.3 for septic shock during labor. So this is how you have to code the sepsis and septic shock cases which when they complicate the abortion, pregnancy and childbirth. So next is newborn sepsis. So what the guideline says, for coding newborn sepsis, you must refer to the section IC16F, the bacterial sepsis of newborn. So codes come from P36 category. So what are the points you have to remember over here? Newborn sepsis is coded differently from the adult sepsis. So you should not use the code A41 codes for newborns. So the age of the patient, newborn or infant, they decide the chapter. So example is 3-day-old baby admitted for E. coli sepsis. So what you have to code? P36.4 for sepsis of newborn due to E. coli. So always use P36 chapter 16 for neonatal sepsis. So the ninth guideline is hemolytic uremic syndrome associated with the sepsis. So what is HUS? Hemolytic uremic syndrome. So it is a combination of hemolytic anemia, thrombocytopenia and acute kidney injury. So sometimes it is triggered by infection including sepsis. So what is the coding rule for hemolytic uremic syndrome? If the patient is admitted for HUS, which is caused by infection, so then you have to assign the code D59.31, the infection associated hemolytic uremic syndrome, which is coded as a principal diagnosis. So other codes are the underlying systemic infection, for example like sepsis A41, or organ dysfunction if severe sepsis is present. So what is the example? A patient admitted with hemolytic uremic syndrome due to sepsis from E. coli or acute kidney failure. So what is the coding sequence? D59.31, that is infection associated HUS, which is the principal diagnosis, or A41.4, sepsis due to E. coli, or N17.9, acute kidney failure, or R65.2, severe sepsis if it is documented. So why D59.31 it is first? If the reason for admission is HUS associated with sepsis, or D59.31 is sequenced as a principal code. So this is how you have to code HUS related conditions. So next guideline is about methicillin resistant Staphylococcus aureus, that is MRSA condition. So how to code MRSA infectious properly? The first one is selection and sequencing of MRSA codes. So how do you select? How do you sequence the MRSA codes? So there are two main possibilities. The first one is combination codes, which is most preferred, and second is MRSA plus specific B95.6 plus infection code. So when combination code does not exist. So let's look after the combination codes for MRSA infection. So what is a combination code? One code that describes the infection, the casual organism MRSA. So what are the examples? A41.02, sepsis due to MRSA, and J15.212, MRSA pneumonia. So T81.44, which is for post-procedure infection due to MRSA. So if a combination code exists, you have to use it. So do not add B95.62 MRSA with it. So there is an example if a patient has MRSA sepsis. So what is the correct code? A41.02, sepsis due to MRSA. But you should not always code B95.62. And another example, patient has MRSA pneumonia. Then you have to code J15.212, pneumonia due to MRSA. So this is how you code, this is how you give a combination code as well as a when combination code does not exist. So when a combination code exists, for example, combination code examples are A41.02 for sepsis due to MRSA and J15.212, pneumonia due to MRSA. So these codes, they already include the infection, the organism. So one code covers both the condition plus MRSA. So you should not assign B95.62 with a combination code. Why? Because the combination code already identifies what is a type of infection as well as MRSA. So adding B95.62 would be a double coding. It is not allowed. So example is patient has MRSA sepsis. So what is the correct coding? A41.02, which is the only code you have to assign. So do not assign Z116.11, which is resistant to penicillins. Why? Because MRSA is by definition resistant to methicillin. So methicillin is a penicillin type drug. So therefore coding Z16.11 it is not needed. So because resistance is already included in the MRSA description. So next coding is for other codes for MRSA infection. So when there is no combination code exists, so how do you code? What are the examples or what are the guidelines? So examples like MRSA wound infection, MRSA UTI, MRSA stitch abscess or MRSA cellulitis. So for this you must code MRSA using two codes. The step 1 is code the infection, for example like cellulitis, and then you have to add the organism code B95.62, that is MRSA, methicillin resistant staphylococcus aureus. So example, there is a diagnosis cellulitis of leg due to MRSA. So codes are L03.116 cellulitis of left lower limb and B95.62 for MRSA as a cause of the disease. So this is correct because cellulitis does not have a combination of MRSA code. So again you should not code Z16.11. So even in this non-combination code situations, you should not assign Z16.11 which is resistant to penicillin because the resistance is already captured by MRSA wording. So C guideline is methicillin susceptible staphylococcus aureus and MRSA colonization. So the condition or state of being colonized. So what do you mean by a state of colonization or colonization? It means that a bacteria like MSSA or MRSA, it is present on or in the body. So it does not cause infection or symptoms. So the person appears healthy, but the bacteria live on them. So what are the common sites of colonization? Which is in nose, most common, skin, throat, ground or armpits. So what is the example? A person can have MRSA in their nose, but they can feel completely fine. So this is colonization, not an infection. So MSSA or MRSA versus. So what is MSSA? Methicillin susceptible staphylococcus aureus, which responds to common antibiotics, and MRSA, methicillin resistant staphylococcus aureus, which is resistant to many antibiotics, so which is harder to treat if infection occurs. So both can colonize the body, but MRSA is more concerning because of this antibiotic resistance. So how colonization is documented? Providers may write MRSA screen positive or MRSA nasal swab positive or MSSA colonization or carrier of MRSA. So these terms all mean the patient is carrying the organism without infection. So how do you code for colonization? So what are the ICD-10-CM codes for MRSA colonization? So if a patient has MRSA colonization, you have to assign the code Z22.322. What does this code mean? Carrier or suspected carrier of methicillin resistant staphylococcus aureus. So you have to assign these codes when the provider documents colonization or carrier state. So you should not assign them automatically for infections. Those have different codes. So colonization is not the same as infection. Colonization is the bacteria present. There is no disease, no fever, no pus, no redness, or no need for antibiotics. So infection is illness caused by bacteria. So there are symptoms present, it is needed of a treatment, and it also has a separate ICD-10 codes but not Z22 codes. So what are the example? If a nasal swab shows MRSA but patient has no symptoms, so it results in colonization Z22.322. So a wound is infected with MRSA infection. So code for MRSA infection but not colonization. So why this is important in healthcare? Because MRSA carriers, they can spread bacteria to others, or hospitals take special precautions like contact precautions. Colonization may increase the risk of future infection, especially in the surgery patients, people with weak immunity. So because of this, it is essential to identify and code the colonization accurately. So next, MRSA colonization and infection. So what is the key idea? A patient can have both. He can have both MRSA colonization as well as MRSA infection. So these are two different clinical states. So they require two different codes. So what is the coding rule? If both are documented during a hospital stay, assign Z22.322 carrier or suspected carrier of MRSA or a code for the MRSA infection depending upon the site. Example like MRSA pneumonia, MRSA sepsis or MRSA wound infection. Why both? Because colonization does not disappear during the infection. So a patient can still be a carrier even if MRSA has caused disease. So there is an example like documentation is patient admitted with MRSA pneumonia and nasal swab positive for MRSA colonization. So how do you code? J15212 for MRSA pneumonia and Z22.322 for MRSA carrier. Both must be assigned because they reflect different conditions. So what is the important note for you? Colonization is not equal to infection. So they are coded separately. So if only infection is documented, you should not code colonization. So if only colonization is documented, code only Z22.322. So next are the guidelines for Zika virus infections. So you have to code only confirmed cases. So what to code? A92.5, which is for Zika virus disease. So only when the provider states it is confirmed. So you do not need lab test results for this to confirm type of diagnostic test or proof of mosquito exposure. So the doctor's statement confirms Zika is enough for coding. So why is this an exception? Because it is normally for inpatient coding. Confirmation requires lab evidence, specific test results. So for Zika, the guideline says only the physician diagnosis matters, regardless of testing. So this was created during Zika outbreaks when lab testing was limited. So now what is the mode of transmission which does not matter? Even if the chart says mosquito bite, sexual transmission or travel to endemic area. So we have to still assign A92.5 if the provider confirms Zika. So what if Zika is not confirmed? So if documentation says suspectable Zika or possible Zika or probable Zika. So you should not assign A92.5 which is confirmed Zika. So instead you code the symptoms such as fever, rash and joint pain, and also you can code the exposure code Z20.821 which is the contact with and suspected exposure to Zika virus. So when it is a confirmed Zika, assign A92.5. If it is a suspected Zika, you have to assign the codes for symptoms. So next guideline is about coronavirus infections. So what is COVID-19 infection? Infection due to SARS-CoV-2. So you have to code only the confirmed cases. So what does confirmed case mean? A confirmed case of COVID-19, it can be based upon either the provided documentation that the patient has COVID-19 or a positive COVID-19 test result. So either one is enough to assign. U07.1, which is for COVID-19. What is the important exception? So normally inpatient guidelines require lab confirmation. So but COVID-19 is an exception. For COVID-19, if a provider says the patient has COVID-19, you may code U07.1 even without the test results. So do not code. So what cases you should not code U07.1? When the documentation uses the uncertain terms like suspected COVID-19, possible COVID-19, probable COVID-19 or inconclusive COVID-19. So you must not assign U07.1. So instead you have to code the symptoms. For example, if a patient has fever, cough or shortness of breath, or use the exposure code if applicable. So example like confirm COVID-19. So the documentation says COVID-19 pneumonia or a positive RT-PCR test. So you have to assign the code U07.1. So also code pneumonia. So give the pneumonia code. So this is how you code the confirmed cases. So next, how the sequencing of codes must be. So which code is placed first in the diagnosis list. So when COVID-19 is the principal diagnosis, COVID-19 itself is the main reason for admission. Then sequence U07.1 as the first. then followed by the codes describing the complications or manifestations such as pneumonia, ARDS, sepsis, and acute respiratory failure. So what will be the exceptions? So in some conditions, other guidelines require sequencing differently, such as obstetric patients. In the case of obstetric patients, what I have said you earlier, obstetric codes come first. So they have the priority among all the ICD-10-CM chapter codes. So sepsis due to COVID-19. So in this case, you have to follow sepsis sequencing rules. And transplant complications. So in this case, you have to transplant complication coded first. So always check the condition specific guidelines before you give the sequence. So COVID-19 infection that progresses to sepsis. So how do you code? So when COVID-19 leads to sepsis, you must use the sepsis coding rules to determine the sequencing. So coding logic is COVID-19 can cause sepsis, but sepsis rules decide which code goes first. So usually sepsis code first, then followed by U07.1 for COVID-19 and followed with the organ dysfunction codes if present. So there is an example. It is documented as sepsis due to COVID-19. So what will be the coding? How you give the coding? A41.89 for other sepsis followed by U07.1 for COVID-19. So you have to again add the organ dysfunction if the severe sepsis is present. So how would you code COVID-19 in pregnancy, childbirth or puerperium? So if a pregnant patient, so obstetric guidelines override all others. So whenever a pregnant patient has COVID-19, so first what series comes first? O98.5. So then you have to add COVID-19 code. So followed by any complication again, any organ dysfunction or any failures. So here is an example. A COVID-19 in a 32-week pregnant woman with pneumonia. So what is the code order? O98.52, that is a viral infection complicating pregnancy. So then U07.1 for COVID-19, then J12.82 for COVID-19 pneumonia. So the third guideline is COVID-19 infection in a newborn. So newborn coding follows the neonatal rules again, but not the adult rules. So if the newborn is diagnosed with COVID-19, so use P35.8 first. So then followed by U07.1 COVID-19 code as an additional code. So the code must reflect that the infection occurred in the perinatal period. So in the case of lung transplant patient, so COVID-19 infection in transplant patient is treated as a transplant complication. So in this cases, first code the transplant complication code, then followed by U07.1. So then in a specific COVID related manifestation. Why? Because transplant guidelines require that the transplant complication code is sequenced first when the infection impacts the organ. So these are the guidelines regarding to COVID-19. So this is for today's session. I hope this session has helped you. So in the next session, you will be learning about the continuation of Chapter 1 ICD-10-CM Coding Guidelines. Thank you.